Thank you very much, Doug, and we're right on time. So while we're waiting for people to ask some questions, I think Valerie and I have a couple of questions.
I think we have time for us to ask some questions this time. This is just a question for the surgeons on the panel. There's been some discussion sort of this morning about neoadjuvant treatment and its role for sort of the surgical management of cholangiocarcinoma. I know, John, in particular, you mentioned some sort of factors that's indicative perhaps of better or worse response potentially to neoadjuvant treatment. And we've seen in the liver transplantation talk today that there was some really good response in the perihilar PSC patients. But do you think there's any other, strong indications of when perhaps we should start to be using neoadjuvant treatment in our non-PSC patients having surgery?
So you're asking me?
I'm asking you.
I think we don't know. We don't know, and I think the initial recruitment to some of the smaller trials that are being done, I think probably would give us a clue to that. I think I was very clear that I think we're really talking about intrahepatic, because firstly you've got more alterations there, so you're more likely to be able to find something appropriate for the patient, and you do not, in general terms, have the problem of either no tissue or the problem of biliary obstruction and sepsis that you get with perihilar disease. I mean, the patient we resected of John's was an accidental. Well, it's not an accidental section, but it was not anticipated that they would come to such a response. But I think if they do, I think we should offer. If the patient wants it, we should accept it. Although we're doing it outside of normal criteria, I think we're not going to advance unless we try.
Yeah. And Danny, what do you see for the role of it in gallbladder cancer?
So one of the problems is actually having a neoadjuvant regime that works. And I think we are still far away from that for gallbladder cancer, because if you look at all the current trials, gallbladder cancer patients are included in the whole biliary tract cancer patients. And we know definitely that each of these biliary tract cancers behave differently. So it's quite hard to justify, especially in resectable cases, offering patients neoadjuvant treatment rather than an operation upfront with the current evidence we have.
It's just worth noting the US trial, NIH US trial on neoadjuvant therapy for gallbladder cancer failed. It's closed because it failed to recruit. So this is not an easy area.
Actually, we'll go to the floor first before I ask my question. So, Professor Bernales.
Thank you, Shahid. My question is regarding the aspirin trial. This is a huge effort. Congratulations. This is very needed. But you know that Bolivixibat has recently been approved for pruritus. Showed positive results in a phase 2b clinical trial. So this is an inhibitor of the recap of bile acids in the gut. We don't know how it might affect the disease progression. We need to see prospectively. And then we have the Norurso phase 3 trial with that in the intermediate endpoints were positive. So I guess these trials will come out soon to the patients. So I was wondering how they might affect the design and conclusions of the aspirin trial.
Yeah. So in terms of, that's an excellent question. So we have some other potential trials available in PSC patients. And when I recruit patients or talk to patients, and I say to my fellow colleagues around the country, is to say to the patient that this is a 5-year trial, but you are entirely in control. I know that if we're not recruiting ongoing, then that is an existential threat to the trial. So I want the patients to come in. But I make it very clear to them, at the moment you can't be on 2 trials at the same time for our trial. But I say to the patients that it's entirely up to you. You can leave the trial at any point. If another trial comes along that you think has more important endpoints to the trial that I'm doing, it will in no way affect our relationship. I'm still your doctor and whatever. So I make it clear that. But the other trials, so the phase 2 is one thing, but it doesn't necessarily translate in that it's going to be a phase 3. The other thing is that the Norurso Whether that's actually going to affect cancer risk is probably unlikely. And the third thing is that when it comes to trial recruitment in England, yes, even though there may be other trials coming along that we recruit to, typically they will only be at a few centres recruiting a handful of patients, not on the scale of this. And there will be rules on patients with a certain level of fibrosis, etc., recruited. So I do think there's enough patients with PSC to feed these other international trials as well as our own trial.
Okay, so the aspirin trial excluded the use of other kind of drug like Boliviximab or Norurso, I understand from that.
So patients can be on URSO, they can be on ursodeoxycholic acid as long as they're on a stable dose.
But-
They can be on biologics for their IBD,
Okay.
but they can't be on on the aspirin trial and another trial at the same time.
Not as a trial, but now as it becomes a standard of care, let's say with Boliviximab and Norurso is being approved and under use, they can be engaged in the
Yes,
trial?
yes,
Okay.
that would be fine. So standard of care is fine. So we try to make it as real-world a trial as possible. So if they're on any standard of care therapy, even if that standard of care changes, so if they, for example, biologics are allowed, if Norurso becomes standard of care, that would be allowed. Yeah, that's fine.
I just had a question, two very clinical questions. One is the patients with incidentally detected T2 gallbladder cancer, which is very common, laparoscopic cholecystectomy, you pick the cancer up. Is it still correct that the optimal management is the patient should have a liver resection, portal lymphadenectomy, and then start chemotherapy after that with full surgical staging? Or is it reasonable sometimes to just proceed with the adjuvant capecitabine? Because we've had 3 or 4 of these recently where we have just given the chemotherapy, but then I was thinking if they're fit enough, they should then have the liver resection and lymph nodes removed, shouldn't they, before chemo, or does it not matter?
So,
sorry.
sorry, you go first. You go first.
So I think the current evidence say that if they are resectable, there's no other disease elsewhere, you can go for resection first and then give adjuvant chemo.
No.
But
No, Danny, my question was if you've got an incidentally picked up
it's
cancer.
incidental. So
Okay.
in terms of if it's T2, we would still recommend liver resection and lymphadenectomy and cystic duct margin assessment. So that is the first treatment and then adjuvant.
And if doing that takes the patient beyond the 12 to 16 week window for adjuvant, you wouldn't be concerned about that?
I think the reality is that you want to try to get the patient staged appropriately. So if you do the resection and then you find the lymph nodes are clear, liver resection is clear with no residual disease, and then that's the first point of treatment, then you can start your chemo.
Okay, so I should be telling my surgical colleagues if they're fit for surgery, then
If they're fit
do
for surgery.
proper surgery and then we'll take it from there.
Yeah.
So I think there is an issue of these very early stage gallbladder cancers. And Anita, I don't know if you want to comment because you've sort of done most on this. There is doubt about some. There is certainly a grey area where it's maybe not necessary.
Yeah, thanks, John. Anita Balkrishnan, I'm one of the liver and pancreas surgeons from Cambridge. So we did quite a big international study looking at various T stages and the outcomes from surgery versus just cholecystectomy. And it's very difficult, as John says, because to accurately assess this, you do need to stratify it by lymph nodes, etc. And often from the initial operation, they haven't had adequate lymphadenectomy, they're often understaged, etc. So T2, interestingly, was the only tumour stage where at univariable analysis had a benefit to resection, not at multivariable. And it's difficult. I think our practice would still be to resect. I completely take your point. By the time we've resected the second time, they're well outside the usual chemo. I still think we would recommend resection first, looking for residual disease in the tumour bed, proper lymphadenectomy. I still think for T2 it's useful.
And I just had one other question about transplant. Is the immunosuppression regimen any different? So would you give different immunosuppression for cancer patients versus non-cancer indications?
That's a good question. I mean, in the protocols, it was not specifically written what sort of immunosuppression should be used. I think there's reasonable evidence for the reduced risk of tumour recurrence with mTOR inhibitors use, but that hasn't been mandated. I think for the NET programme, they've got some kind of commissioning approval to use mTOR, but it's still sirolimus is available to everyone. So, but we've not specifically been tailoring immunosuppression at present, and it's not in the protocol. Thanks.
I just had before we come to, I know you've been waiting very patiently, but on a related note about the resection, and looping back to Benjamin's very moving talk earlier about monitoring post-resection, for gallbladder cancer, did you have any agreement, recommendations on monitoring post-resection?
So I think most of our HPV experience in terms of surveillance comes from colorectal liver mets. If we look at gallbladder cancer and biliary tract cancers in general, the recurrence tend to be in the first 2 years. So if we look at what we practice in most centers, it's 6 monthly CT scans as initial surveillance, and some do tumor markers.
And did you put the 6 monthly in the guidelines?
I think we did, yeah.
Okay. Yep.
Thanks. Hi, Rob Young here, a surgical trainee in Liverpool. Another one on gallbladder cancer, specifically to achieving clear margins. Intraoperative frozen sections, is that something that you think's useful for these operations, and also is that included in the guidelines?
So what we included in the guidance was the cystic duct margin to make sure that whether you need to do a bile duct excision or not, because that then is quite a major operation if you need to do a bile duct excision. And then when you do the bile duct excision, you send both the proximal and distal ends for assessment as well.
Brian Davidson from the Royal Free. Question for John. You'll be surprised to hear I agreed with most of the things you actually said today, so I'm very
Brian,
surprised.
I'm overwhelmed. I'm overwhelmed. But let's go to the point.
So the point... I had two questions for you, actually, John.
Right.
The first one is a sort of big picture question about robotics or minimal invasive surgery. As you know, there's a huge commercial drive, financial drive to support robotics. The majority of patients that are having robotic surgery, it's under circumstances where there is no evidence that their procedure is going to benefit and it's not going to be cost effective. You've now demonstrated some data today from the Orange Segments trial that there's a significantly higher risk to the intervention, or certainly the suggestion of a significantly higher risk.
It's not significant, it's clinically relevant, I think.
What should you or us as a group be doing about this situation?
So, boys with toys. How would you stop boys playing with toys? I think it's really difficult. There is a huge amount of money being put into this, and it's being promoted, and patients want it. And I'm not entirely. And as you know, my unit does it, and I'm not an enthusiast for this, but that is just the reality. And their argument is, well, this is the future, and although at the moment that you certainly can't demonstrate the results are better and they're probably worse and it's more expensive, their argument would be that it's all going to be done like this in the future. I suspect in career terms it's not going to affect either of us.
Yeah, but that doesn't mean to say that we can't have a view on it, and I'm not sure what your view is.
I don't think
we cannot
I
have a limitless expense from the NHS on robotics, so somebody has got to make the decision.
So, personally, I don't think it should be. My own view is it shouldn't be done outside of a clinical trial. That's my simple view.
Okay, funded by NIHR.
Well, it can't be industry funded, is it? Because we know what will happen if it's industry funded.
Yeah.
It'll either never be published.
Well, we have to do the trials, or we're going to get into exactly the same situation as we have with transplantation, is it not?
Yeah, I think so.
Okay, I'll leave it at that. Thanks, John.
Yes.
Sorry, just a couple of quick questions for Danny about the BSG guidelines for gallbladder cancer. Sorry. Did you say that we would now be asked to, following your pathology guidelines, are we looking at the nodal stage by location or by number? Because
Say that
AJCC
again.
8 is usually by number.
Say that again, sorry, Anita.
For the nodal staging,
Yes.
will you be recommending the pathologist assess it by nodal number or nodal site of, location of the nodes?
So it's the TNM stage will be N1, N2.
So it's still following AJCC 8, not
Yes.
7? Okay.
Yeah, it's still following
It's
that,
still
yeah.
8, okay.
The Royal College of Pathologists, I don't think have updated their pro forma
Okay.
to follow the current
Okay,
AJCC. I think the current one is the 9th edition.
okay, right.
But that's what that has been recommended.
And I think you also suggested we were going to biopsy the primary. Is that for all cases?
No. So we try to look for other sites because
Yeah.
obviously the primary tumor biopsy is difficult.
Yeah.
So our preference is ultrasound CT guided of usually there's a liver met or other sites, Omentum. But if those all fail,
But you're
then-
talking for the advanced setting.
yeah,
You wouldn't require it for...
not for operative. No, not for operative.
Thank
no.
you.
Doug, I have a question. We recently had a common patient. One of the reasons for the strict criteria is clearly the lack of organs. If we in the UK were doing more living donor liver transplants, like they do in many other countries around the world, and if we therefore had more organs, is it ethical to loosen the criteria or not?
So there is already a national drive on redeveloping live donor liver transplantation, and there's a sort of proctorship model that's been established with a national team to support centres to build their experience to independence to do live donors. So there's certainly efforts going on. I think one of the issues about liver selection criteria is that to some extent you cut your cloth according to the expectations of what you can deliver to the patients, because we know there's lots of patients who don't meet these criteria that could have a good outcome after transplantation. So one of the topics for discussion now that the live donor program is kind of going again is, should the criteria for live donor transplantation be different for deceased donor transplantation, which then liberates you from some of those constraints. And I think generally people feel that would be reasonable, because there's no doubt there's plenty of patients with good outcomes that just don't meet the criteria at present. But I suppose within this specific pilot, given the costs of the PBT for the perihilar cholangiocarcinoma, NHS England haven't reached a decision that they'll resource it for this indication. And that is one of the constraints in terms of what we might do in the short to medium term. I think ultimately we'll probably get to a point where for live donor we do have different criteria.
Yeah. I suppose the ethical consideration has to include that it's not risk-free to the donor. There is a reasonable morbidity risk to the donor, I guess. I think we should probably end there. We are exactly on time. Well done, Dr. Crowley.
Thank you, Professor Khan.
Thank you to all our speakers for their insightful sessions. Thank you to the audience for your thoughtful questions and engagement throughout the morning.
You'll be pleased to hear it's lunchtime. So please feel free to go just outside in the wine tower area. You'll know it when you see it because there'll be lunch there. The afternoon sessions are going to start promptly at 2 o'clock. So please make sure you're back here for 2. But in the meantime, just outside, we've got some poster sessions. I think people are going to be standing by their posters from about 1:20. So please come along and have a chat and have a look at the posters as well.
And
so
just one final thanks from me. This is the end of the CCA UK joint AMMF session. Many thanks again to the AMMF for hosting us at your amazing conference. And have a great lunch.